Yes, sir, we are live.
Ashray, can you introduce sir? Ashray?
Yes, ma'am. We are live, ma'am. Good afternoon, all the participants. Welcome for this session on the basic principles of antibiotic prescription. And today we are very proud to have with us Dr. S. Balasubramanian, sir. Sir is senior consultant in pediatrics at Kanchi Kamakoti Child's Trust Hospital. Sir has 126 indexed publications, 600 CME sessions with 10 orations to his credit. Sir is also a very distinguished DNB teacher and has been an awardee from National Board of Examinations. Very warm welcome to you, sir.
Thank you.
Sir doesn't need an introduction for a pediatric population. Sir himself is a legend and teacher of teachers, a passionate teacher who simplifies concepts for all postgraduates and always there to teach postgraduate. Thank you so much for agreeing to be there, sir. Thank you so much.
Thank you. Shall I share the screen, ma'am?
Yes, sir. Yes, sir.
Yes, sir.
Is my screen visible, ma'am?
Yes, sir. Yes, sir. It's coming as started sharing.
Is it okay? Is it okay?
Not yet.
Still not yet.
Not yet. Sir.
Now?
No, sir.
No?
No, sir.
Oh, sir, 1 minute. Let me stop sharing and then come back. Now?
Not yet, sir.
Now is my screen visible?
No, sir. Not yet.
1 minute. I'll just close it. I don't know. I'll stop sharing and then come back once more. Yeah.
It's visible, sir, now.
Visible.
Yes, sir.
Okay. Thank you, Dr. Naglata, for asking me to do this session for what I understand is meant for postgraduates in pediatrics. I have chosen a topic of basic principles of antibiotic prescribing. The learning objectives in the next 55 minutes would be, we'll be looking at the selection of antibiotics appropriately and the steps that one should follow. We'll talk about some principles of combinations of antibiotics. We would discuss escalation, de-escalation, and discontinuation, which are new mantras in pediatric infectious disease and antimicrobial stewardship. I will briefly discuss IV to per-oral switching and end with the principles of principles of prescription writing. Now, before you start writing a prescription of an antibiotic, you should always think before you ink. What do you think? You first, yeah, 1 minute. I think I have shared the wrong one. I'll just come back. Yeah. 1 minute. Some problem. I don't know what went wrong. Just a minute. Yeah, is my screen visible now?
Yes, sir.
Yeah. Sorry, there's some problem. Sorry, just a minute. This decision will be taken based on clinical illness. Okay.
So the screen is not visible, sir. It says it has started screening.
1 minute.
Sharing.
There's some problem. I really don't know. Something went wrong. Oh, just a minute. Okay, there is some problem. Okay, fine. I'll just now is my screen visible?
No, sir.
Just a minute. I just close it.
So you can actually try leaving once, clearing all the apps, and again joining and start sharing. So that will work.
I'll just leave it. I'll just leave. Yeah.
Yes, sir.
Yeah. I'll just try to share the screen. 1 minute. No, somebody has disabled screen sharing.
Now you can, sir.
Yeah. Okay, there is some smudging. It doesn't matter. The learning objectives will be, as I said, the basic principles of selection of antibiotic, continuation, discontinuation, IV to oral switch, and prescription writing. And actually, these slides are from Pediatric Infectious Diseases module of Antibiotic Prescribing made, you see. I'm sorry, there's some technical problems smudging in the slides. I could not open the real laptop slides. And thanks to Dr. Dhanalakshmi, my colleague and senior consultant at Pediatric Infectious Diseases, who actually had prepared the slides. Now, before you start discussing, the first question that you ask when you practice in office or in hospital is antibiotic needed? And the moment you ask that question, you should think before you ink. What should you think? You must know the child's illness, whether it is infective or inflammatory.
Sir, are you sharing the screen?
Slide,
It is not visible.
screen is not visible, Bala sir.
Okay, there is some. I
now
don't
it
know.
came.
1 minute.
Now it came. Okay, now it came. Yeah. Now it is visible,
now
sir.
we
Bala
have-
sir, it is visible now.
1 minute. I will share some other PowerPoint. The problem is the PowerPoint which is being, I don't know what went wrong. 1 minute, just a minute. I'll just go to that. Okay. Now is my screen visible?
Yes, sir. Screen is visible, sir.
But it's not
Okay,
full screen, sir.
okay.
Not
Now full screen.
full screen.
Okay. Now the question that you ask is this illness infective or inflammatory? Then you ask if it is infective, whether it is viral or bacterial. Then if it is bacterial, you try to choose the appropriate antimicrobial agent. Yes. We pediatricians always try to differentiate any infection as viral versus bacterial. In fact, this is the most important step in disciplined antibiotic therapy. If you have a child who has high fever on day 1, getting better by day 3 or 4, often with biphasic pattern, child is otherwise active, playing, and during the intrafebrile period, the child is pulling at your steth in the clinic. More than one system is involved, diarrhea plus cough. More than one family member is involved. That is viral. On the other hand, you have moderate onset, peaking by the fever is increasing by day 3, 4. Child is not well looking, whether it is with fever or without fever. In intrafebrile period, child is lethargic. And there are symptoms related only to one system. There is no contact with somebody who's ill. That is bacterial. Before we start discussing the principles, I have shown here 2 X-rays.
Sir, it's not
These are.
visible, sir.
Pardon?
No, the slides are not moving, sir,
X-ray.
actually.
Where in one child, both the children have got respiratory distress. In one child, you get a homogeneous shadow, what looks like a round pneumonia nearly, the one X-ray on the left. And on the right shadow.
Sir, Bala sir,
Yeah.
Bala sir, actually slides are not moving. We are not able to see the X-ray slides.
Oh God. Okay, I'll stop sharing and log in once more.
It's still on slide 1, sir. Yeah, it's.
No. Technical problems. Just a minute. Yeah, now slides are visible. Hello.
No, sir, not visible. Not visible.
I really don't know.
Sir, you can send it to Naglata, sir. You can email to her. She will present it.
The problem is the file is too thick. It may or may not
Too
go.
big. Okay.
That's about. Now,
Not it, sir.
okay, I'll just do one thing. I'll go back to the PowerPoint. Now,
Yes, sir, it is visible.
thank you. Now you have two X-rays, the one on the left and one on the right. The left shows a homogeneous opacity. The right also shows a homogeneous opacity, but there's a difference between the two. In the right X-ray, you find that the interlobar fissure is pulled up, and here it's a homogeneous shadow. So both children have respiratory distress, but here, when there is a homogeneous consolidation like this, it's bacterial. On the other hand, the one on the right with the pulled up minor fissure with a shadow like this suggests that it is more of an upper lobe atelectasis due to a viral infection than pneumonia. Before you select the optimal therapy, you take the remaining steps. You must consider the age of the child and then perform the diagnostic test. And then you should consider PK/PD of drugs. You should consider target attainment. I'll describe later one by one. You should also consider empiric and definitive therapeutic decisions separately. And there must be some special considerations like liver disease, immunocompromised state, renal disease, etc. Oh God. Again, it is smudged. 1 minute. It's a whole thing is, I do not know what has really happened. No. I'm extremely sorry. Technically, I'm very weak. That's it. The problem is 1 minute. Let me again stop sharing and come back. Just a minute. I will leave and come back in 2 minutes. I'm extremely sorry. I will leave and come back.
Yes, no problem, sir.
Is that visible now?
Not it, sir. It says sharing, sir.
Now?
Yes, sir. Visible, sir.
Okay. Now it's smudged. It doesn't matter. I don't know what has happened. This is the Okay. It doesn't matter. I'll manage you even without slides. Don't worry. Don't worry. Doesn't matter. And you should also always look at the age of the child. The age of this child is going to determine whether it is likely to be bacterial, it's viral, which organism is likely to cause. For example, if it is pneumonia, below 5 years, you're not going to think of mycoplasma. Above 5 years, you're always going to think of mycoplasma, and there is pneumonia. Below 3 years, you're not going to consider streptococcal pharyngitis. Above 3 years and above 5 years, any sore throat, you're going to consider bacterial pharyngitis. Step 4 is the performance of diagnostic tests. You see here in this picture, 2 children who have severe sore throat. The one on the left has got exudates, it's dirty looking. The one on the right has got a beefy red uvula, and tonsils are so red and inflamed. You see petechiae in the palate. Definitely you might, on the left, you might think of diphtheria or viral or EBV. On the right, you may think of a scarlet fever, or you may think of even a viral infection, in which case you have to do per diagnostic test like throat swab. And in the diagnostic test, we should not forget the culture of culturing. I'm sorry for the smudging of the slides. I don't know what went wrong. You must always remember, blood culture should be done in any febrile child before starting antibiotics for systemic infection. In general, a specimen or an aspirate from the tissue or fluid, for example, pleural fluid, pericardial fluid, ascitic fluid, are much better than swab. You should not do rectal swab for bacterial cultures. They are useless. You must do only a stool culture. And you should transport it as soon as possible. In fact, in meningitis, if you want to get the best yield, you must straight away put it into the medium, run to the lab and go and give the specimen. And you should give adequate amounts of sample. Otherwise, the pathologists, even if you send the whole body, they will say specimen is insufficient. There are several non-culture methods of bacteriological confirmation. What are they? You can do direct microscopy. For example, a gram stain in the CSF will give you the diagnosis of pneumococcal meningitis. And in the pus, you may pick up pneumococcus. And A-B presence will always confirm tuberculosis. Similarly, antigen testing for pneumococcus, for meningococcus in the CSF might give you the confirmatory diagnosis. And of course, in diseases like, scrub typhus, you have nothing else other than typhus IgM. Maybe PCR is coming up in a big way. And diseases like, COVID-19, tuberculosis, PCR is coming up in a big way. So you should do these methods for confirmation of bacterial infection. Step 5 is to consider antibiotic susceptibility. Look at the culture report here. E. coli. And it says it is sensitive to almost all the antibiotics except nalidixic acid and perhaps cefotaxime and ceftriaxone. And, the one on the left shows it's sensitive to cefotaxime. The one on the right shows it is not sensitive to cefotaxime and ceftriaxone. Obviously, you know that this is ESBL. And you should always remember some pathogens, like, for example, Klebsiella, even though the lab gives you a report, ampicillin sensitive, it won't succeed. So intrinsically, it won't succeed. Protease may not respond to only ampicillin. ESBL producing organisms will not respond to your cefotaxime and ceftriaxone, may respond only to quinolones or aminoglycosides. Step 6, this is a very important step. When you give an antibiotic, you must know what is PK and what is PD. PK means the movement of any antibiotic. For example, you give amikacin intramuscularly. From the intramuscular region, you expect amikacin to act on the kidneys. So that is the place of its pharmacological activity. And it is also excreted through the kidney. So how does this antibiotic move from the site of administration into the blood, site of action? What does it do? And how does it get excreted? That is PK. On the other hand, the term PD means the concentration of the drug along with its pharmacological and clinical effects. That is PD. When you talk about PK/PD, this curve is very, very important. What does this curve mean? Look at this curve where you have 3 data. One is concentration on the left. Second is the P concentration called Cmax. Third is the AUC, area under the curve. Fourth is the MIC. For example, you have something like pneumococcus in the lung. This is a low MIC. You want to maintain the drug above the MIC, and you want to know when it achieves the peak, and you want to know how long the antibiotic concentration is above the MIC. That is what this curve depicts. When you talk about pharmacodynamics, you have what is called 2 types. I'm sorry for the smudging of these slides. You have time-dependent and concentration-dependent antibiotic. Penicillin, cephalosporins, carbapenem, they're all concentration-dependent. They have a short half-life, most of them. So if you want to give these drugs to somebody with serious infection, you will have to give them repeatedly, 4 hourly, 8 hourly, even 2 hourly. And when you choose a drug with a short half-life, you always have a problem of maintaining the serum levels and topping up. It's almost like somebody who wants to have a kick with whiskey. He has to have a peg almost every hour to maintain his alcohol level. It's something like that. So whenever possible, you must choose a drug with the longest half-life. Typical example, that is one of the reasons why ceftriaxone, which has got a half-life of nearly 52 hours, is preferred to cefotaxime, which has got such a short half-life. That's one of the reasons cephalosporin, among the cephalosporin. Ceftriaxone is the most popular cephalosporin. The second is, when you use drugs which are concentration dependent, you always use a loading dose. What is a loading dose? You give a high dose in the beginning. High dose in the beginning. If you give a low dose in the beginning and repeat it, it will take a longer time for the steady state to achieve, to maintain the concentrations above the MIC. But on the other hand, if you give a very heavy dose in the beginning and then top it up with repeat doses, the steady state will be maintained above the MIC. Typical example is somebody with meningitis, somebody with septic shock. You try to give ceftriaxone. The dose is 100 milligram per kg statum, followed by 50 milligram per kg BD. It's not 50 milligram per kg BD. So that is the reason is you want to reach the high plasma concentration immediately and maintain it at maintenance doses. And the administration of loading dose helps to prevent the development of resistance. And it is extremely useful in giving drugs like vancomycin. For example, vancomycin for pneumococcal meningitis, you give loading dose first, followed by maintenance dose, ceftriaxone 100 and vancomycin 20 or 40 mg per kg. That's what you load with. Again, the route of administration is important, and also the dose you use is important in the antibiotic effect. For example, we all know that in Streptococcus pneumonia infection, that is the IPD, invasive pneumococcal disease, the minimum inhibitory concentration varies from site to site. For example, for lesions where there is no biofilm formation, for example, in meningitis, you want to maintain a higher concentration since the MICs are arbitrarily kept high. That is because you want to ensure that meningitis is cured. On the other hand, if you have a lesion in the ear or in the lung, the MICs are low. So if you use an antibiotic which has got a short half-life, of 1 hour, the levels will go up and tend to fall down. If you use an antibiotic with a half-life of 6 hours, the levels will be maintained for a longer period. But then, if within 6 hours, if it falls, you don't want that to happen in meningitis, you top it up. Second is once a day versus intermittent effusion. This is a principle which is very important for aminoglycosides. For example, earlier, we used to give aminoglycosides in BD doses, and this increased the toxicity of nephrotoxicity as well as your ototoxicity. Now, scientists have understood that it is enough if you use aminoglycosides, amphotericin B, once a day, even once a day or twice a day. The reason is these drugs act by concentration. That is, they adopt a mechanism of concentration-dependent killing. It is enough if you give one dose, heavy dose, and you maintain the peak with one dose alone, reduce the side effects. Second is target attainment. In fact, the slides are smudged. I don't even need to read what is there. This is a very important concept for us to be rational in deciding how to hit a bug or a disease hard or soft. I will just give you examples. You have a child who has got impetigo or pyoderma. You know, pyodermas are mostly self-limiting. They will get cured even without any intervention if the immune response is quite good. So your target attainment rates can be as low as 40 to 60%. It's not necessary that you should treat pyoderma aggressively. So that is low target attainment. Medium target attainment. You have disease like pneumonia. You have disease like your pyelonephritis. They don't kill immediately. Of course, they can. They don't kill immediately often, but they result in end organ damage. For example, a pyelonephritis will lead to scars. Here, your target attainment ratio should be around 80 to 90%. On the other hand, if you have somebody who has got a life-threatening infection, meningitis, sepsis, if you don't treat, they will die. Here, your success rate should be high. Why should I talk about target attainment? When you treat a child with antibiotic, if there is a life-threatening disease where your target attainment ratio should be nearly 100%, you have to use empirical antibiotics aggressively in the beginning. On the other hand, if your target attainment rate is low, for example, in impetigo, you don't have to use carbapenem for treatment of impetigo, linezolid for treatment of impetigo. That is the concept of target attainment. Always, the next step is take these therapeutic decisions depending on the cure rates. And as I said earlier, the mantra today is escalation and de-escalation, arohanam and avrohanam. Whenever there is a sick child, you escalate. Whenever you don't have a sick child, for example, there is a child with pneumonia and hypoxemia, you hit hard. Pneumonia who is very stable, you don't hit hard, you can give oral antibiotic. And here again, once the pathogen is identified, you go to the narrowest spectrum possible. As much as people talk about rational antibiotic therapy and say, do not use, misuse, abuse antibiotic, you must remember in a child who is critically ill, there is no point in saying, no, antibiotic stewardship, I won't be using antibiotics. If you delay antibiotic administration in the golden hour of sepsis, you are likely to end up having more morbidity and mortality. And your antibiotic protocol should always consider risk stratification to improve antibiotic selection. When it comes to definitive antibiotic therapy, if you suspect a child to have a bacterial infection, you should send appropriate samples wherever necessary, urine, blood, CSF, etc. And you don't wait for the reports, you start antibiotic empirically. And then based on your microbiology input, you step down to the narrow spectrum as per drug susceptibility testing. However, majority of our prescriptions in pediatric practice, both IP and OP, is only empirical therapy. We act like kings. We don't have evidence for most prescriptions. When you can't culture an organism, for example, in pneumonia and AOM, pneumonia, you get only 10% sense to yield. AOM, you hardly do myringotomy to prove the bug. And if you have a difficult to culture organism in the lab, H influenza very rarely grows. Slow grows like Brucella. Culture is not available. Rickettsial, leptospiral infection. You don't have culture facilities. And most importantly, in practice, somebody who has already received antibiotic, 5 days fever, 3 antibiotics given, you can't prove enteric fever at all with cultures. So you have to resort to empirical therapy. This is a very important slide. Empirical therapy in office practice, if you ask me, there are only 5 classical indications. What are those 5 classical indications? Let us go through that one by one. High probability of bacterial infection while you are waiting for results. For example, you have a child who has got 5 days fever with dysuria. You know it could be UTI. You're going to ask for urine routine culture and blood culture. Then you're not going to wait for the cultures to come after 3 days. You're going to start antibiotic. High probability of bacterial infection. You don't wait for laboratory results. 2, high probability of bacterial infection where waiting is dangerous. Classic example, septic shock. You can't say, I am a rational prescriber, I want lab to tell me what bug it is, child will die. Pneumonia, meningitis, you can't wait. You take cultures, you do investigate, but don't wait for starting antibiotic. So there is a high probability of meningitis being bacterial. 3rd, high probability of bacterial infection in spite of absence of proof of infection. Please read the sentence. Absence of proof of infection. For example, you have a child with dysentery, blood in stools. No, the WHO algorithm says if you have dysentery, you give antibiotic. Watery diarrhea, you give only zinc. But somebody doesn't do stool culture or blood culture for dysentery. So you don't look for proof of infection for dysentery, you start antibiotic, isn't it? 4, suspected viral infection with atypical progress. This is something very, very important. For example, chicken pox. Chicken pox is one exanthem where fever is not very prominent. But on the other hand, if you have some child with chicken pox who has fever for more than 4 days, you should immediately start thinking of secondary bacterial infection. Mind you, chicken pox, if a child has got fever on the 5th day, please start thinking of bacterial infection. That's an atypical progress of a viral infection. In fact, even in dengue, if fever crosses 7 days, you should always think of starting an empirical antibiotic. 5, uncomplicated near certain bacterial infections. What do you mean by that? Otitis media, bulging drum. You don't do a myringotomy and ask for culture, straight away start. You have pyoderma with lymphadenitis. You don't do cultures, they are uncomplicated near certain bacterial infection. But if you ask me, 95% of our antibiotic prescriptions in office are all empiric, coming under one of these 5 groups. Last, special consideration. What are the special considerations? You must always elicit history of drug allergy. Somebody who has got penicillin allergy, you can't give a cephalosporin. And for intracellular pathogens, like for example, Listeria and Salmonella, you use specific drugs. For example, one of the reasons why azithromycin is so effective in typhoid and paratyphoid is because azithromycin is an intracellular antibiotic. Okay. Liver and renal functions, hepatitis and nephritis and renal failure, they are special consideration. And last, Physician assessment of the likelihood for deterioration, mortality is another special consideration. Whenever there is a liver disease, you must modify the antibiotic dosage if you are going to give ceftriaxone, metronidazole, chloramphenicol, capsofungin, tigecycline, clindamycin. Whenever there is a renal disease, we know vancomycin dose has to be adjusted, aminoglycoside dosage, amphotericin B has to be adjusted. But one important concept that you must remember, don't worry about renal failure. You give the loading dose. You give the regular dose, first dose. Do a creatinine. Don't worry about renal dysfunction if an antibiotic is indicated, even if there is renal failure. Only thing is you adjust the dose based on creatinine and several formulas available. Coming to antimicrobial combinations, why do you use them? You want to prevent resistance in TB, Pseudomonas. You want to inhibit beta-lactamase by using clavulanic acid produced by Moraxella or H2 or MSSA. The combinations, like political combinations, can be of several types. Synergism, where 1 + 1 becomes 4, where the combined effect of two drugs used is greater than the independent effects if they are given separately. Typical example, penicillin plus aminoglycoside, beta-lactam plus aminoglycoside. They are synergistic for Streptococcus viridans, Enterococcus, and gram-negatives. They work better if they are given together. It's like some of the opposition parties, when they work together, they will win the elections. Antagonistic, when the combined effect is significantly less than the drug's independent effects when tested separately. Typical example, colistin plus tigecycline has ended up in disaster. They are antagonistic. Similarly, in pneumonia, penicillin combined with doxycycline or tetracycline has had adverse prognosis. Similarly, doxycycline combined with cotrimoxazole and scrub typhus, patients do badly. Additive, where 1 + 1 is only 2. 1 + 1 is only 2. It is not going to become 3. Typical example is your ampicillin and cloxacillin. It's only additive. It's not synergism. Indifferent, where the combined effect is simply the effect of the more active drug alone. Typical example, enteric fever, cefixime plus azithromycin, cefixime plus gatifloxacin, cefixime plus ofloxacin, ofloxacin plus azithromycin. They are no better than the single drug. So these are some of the antimicrobial combinations. Let us take up escalation and de-escalation. What do you mean by the term escalation? When you decide to add a new antibiotic or switch for an antibiotic with a broader spectrum, that is escalation. What is de-escalation? The gear is brought down from 5 to 1. You have started with 3 antibiotics or 2 antibiotics. You reduce to 1, that is de-escalation. You have started with the carbapenem plus aminoglycoside. You de-escalate to beta-lactam. That is de-escalation. Discontinuation, this is what all of us should attempt within 3 days whenever cultures are negative, whenever you are convinced it is not bacterial at all. De-escalation has got a lot of benefits. It reduces the costs, reduces side effects, and you also help the community by preventing emergency-resistant pathogens. Let us look at 2 case scenarios. This 4-year-old child, immunized appropriately, has community-acquired pneumonia, has mild tachypnea, is not hypoxic, no retractions. X-ray is taken, it's upper lobe consolidation. Somebody will ask which antibiotic will you use, amoxicillin, ceftriaxone, amoxicillin plus azithromycin, ceftriaxone plus vancomycin. Obviously, most of you will say you give amoxicillin to cover pneumococcus, the most common organism. And you have started amoxicillin, you are given 50 milligram per kg correctly. 96 hours, fever persisting, respiratory distress same. Obviously, you do an X-ray. X-ray is taken. The left lung is opaque. Now you're going to escalate, isn't it? So escalate to what? Meropenem plus vancomycin. The time-tested combination when somebody is very ill. Ceftriaxone plus Clinda to cover anaerobes and MSSA and also H-flu and penicillin-resistant pneumococcus. Piperacillin tazobactam to cover gram-negatives and anaerobes. Vancomycin to cover MRSA. Ceftriaxone plus vancomycin. See, in this child, we escalated to ceftriaxone plus clindamycin. X-ray was like this. And what we did, after escalating antibiotic, we called the surgeon. So antibiotics will not work when there is a surgical condition requiring intervention. For example, wherever there is abscess, we pediatric physicians have to call the surgeon. Wherever there is pus, unless the pus is drained, your antibiotic will not do anything. This is a typical example. We did a wax, and from the pleural fluid, we are surprised. It grew Streptococcus pneumonia, not resistant to penicillin, very sensitive to all drugs. The next question is, we said escalation and de-escalation. We have started with ceftriaxone and clindamycin for empyema. Now it is pneumococcus sensitive to penicillin. Do you continue clindamycin, vancomycin, ceftriaxone, or amoxicillin? Obviously, you can de-escalate to amoxicillin. So that is the principle of de-escalation. In this child, once the child became all right, once the ICD was removed, we wanted to switch from IV to oral. This is called switch therapy. And there are three types. One is sequential, the other is switch, third is step down. Let us look at each of them. Sequential means you have started a parenteral version of a medication. For example, pneumonia, you have given IV amoxicillin. You can discharge a child with its oral counterpart, oral amoxicillin. That is sequential therapy, right? Switch therapy. It may not be always possible because you use drugs like ceftriaxone. There's no ceftriaxone orally. So switch therapy, what is it? Conversion from an IV medication to the oral equivalent. And here, earlier it was thought that you must use the same class of drug, almost like monogamy. Now, it is now agreed upon you can switch from one class to another. It must have the same level of potency. It can be a different compound. Just to give you an example, if you have a child who has got a community-acquired pneumonia with empyema, right? You have treated the child with ceftriaxone and clindamycin, right? You are discharging the child. It is pneumococcus. You can go to amoxicillin, different class, right? Similarly, enteric fever, you have started the child on ceftriaxone. You can switch out to azithromycin as OP, different class. Not routinely recommended. You can always think of switching over, right? That is switch therapy. Step down therapy is converting from IV to oral in another class or to a different medication within the same class where everything will be different. Frequency, dose, spectrum of activity, etc. may not be exactly same. Just to give you an example, you have a child with a urinary tract infection. ESBL producer. You are given meropenem or piperacillin tazobactam. Once the child is all right, you are going to switch to oral drug. And if the ESBL organism is sensitive to quinolone, you can switch over to quinolone itself. It need not be any beta-lactam or glycopeptide. You don't have to go in for drugs like pharopenem. Just because you have given meropenem to the sick child, you don't have to follow up with pharopenem, another oral glycopeptide. But there are some criteria which should be satisfied before you select patients from IV to oral. What are those? There must be an intact and functioning GI tract. The child should improve and should not meet any exclusion criteria. What are the exclusion criteria? You can't give oral drugs to somebody who's on nil oral, appendicular perforation, NG tube with continuous suction, obstruction, severe nausea and vomiting, active GI bleeding, shock. Oral drugs may not be absorbed, loss of consciousness, paralytic ileus or obstruction. In these conditions, you cannot switch from IV to oral. In addition, any switch from IV to oral should be done with a drug which has got good bioavailability, should be well tolerated, and there should be some clinical data supporting it. For example, you have amoxicillin, clindamycin, linezolid, all quinolones, particularly levofloxacin. They have got excellent bioavailability. Azithromycin has got poor bioavailability, cefuroxime more so, but azithromycin works because of high intracellular concentration. Again, quinolones are very well absorbed. Cefixime is extremely well absorbed. And most important thing one must remember, you cannot be treating a few infections orally. This is very important concept. Somebody with infective endocarditis, somebody with meningitis and brain abscess, till now, there is no approval for oral therapy. Why? You want to maintain the drug level above the MIC. Oral is not reliable. In fact, there have been few studies trying oral chloramphenicol for meningitis, but today, nowhere in the world is oral therapy allowed for infective endocarditis, meningitis, and brain abscess. Coming to the last part of my session, I said earlier that you have to ask 4 questions. Is it infection or inflammation? Is it viral or bacterial? What is the organism? What is the probable susceptibility? How ill is the patient? How fast should you act? What route is appropriate? And of course, if you ask me, is there an ideal antibiotic in this world? I would say there is none. But an ideal antibiotic, I am sure, will be available in future. Which is the one? It should not harm the host. It should have the narrow spectrum. It should have minimal side effects. It should be used IM, IV, oral, like amoxicillin or ampicillin. Good distribution to the site of infection, including CNS and bones. And they should have a high threshold for developing resistance like aminoglycoside, amikacin, and it should be affordable and cheap. Of course, this is a huge task to find out the ideal antibiotic. Coming to rational prescription writing. First thing, before you give an antibiotic prescription, you must make a specific diagnosis. Without a diagnosis, your pen should not start writing a prescription of an antibiotic. You must select a goal. What is your goal? What is the objective of writing a prescription for amoxiclav? It should not be an objective of satisfying the medical representative who has met you half an hour back. Select the drug of choice. But I always believe a good physician is one who stops prescribing an old drug last and who starts prescribing a new drug last. Ferropinum is being marketed left and right. You should not be in a hurry to start prescribing without knowing what it is. Know the dosage, know the duration, know the side effects and the effects, and what is the end point of therapy you want to achieve. Of course, you should educate the parents. But one of the things that I follow in my practice is not to prescribe dry syrup by and large. I always prefer tablets or dispersible tablets or even capsules where they open and give. The reason is, if you ask them to prepare a dry syrup, invariably even doctor mothers will make mistakes in the correct dosage. They may not shake well, they may not store it properly. So we should avoid the dry syrup preparations. Ready-use suspensions are better. And antibiotics are not antipyretics. Somebody was joking. Ceftriaxone deficiency is not the cause for fever. And azithromycin deficiency is not the cause for COVID-19 or cough. So think before ink. Having said all this, whenever I speak about rational antibiotic therapy or appropriate antibiotic therapy, people always feel that we are talking something negative. We are not saying you should not prescribe antibiotic. The problem is that if you do not follow the principles, if there is no evidence-based approach, and you say, I am rational, I won't give antibiotics, it will result in mortality and inadequate therapy. On the other hand, if you prescribe antibiotic left and right, you will end up having resistance and side effects. There should be a delicate balance. This balance of mind, prescribing practice, rationality should be maintained. Thank you very much. If there is any feedback, please mail me at sbspeed@gmail.com. I finish in 45 minutes, plus or minus 1 minute. Thank you very much. Over to the organizers. I'm sorry for the technical thing.
No, sir. Thank you so much for that presentation, sir. This is a platform where not only pediatricians are there, actually a lot of undergraduates are there. So I thought it will be ideal for all of us to learn about the basic principles of antibiotics. Anybody has any questions? Ashray?
Nothing on the chat.
YouTube, Bale? Okay.
Nagalata, extreme apologies for those.
No, sir. That's fine, sir. We understood.
It
No
doesn't
problem.
happen. I just put those slides together this afternoon, and then I thought when I saw it, the slideshow was okay. I thought everything is perfect.
Yes, sir. I think there is
no doubt at all in the minds of other people.
Srinivasan, sir. Welcome. Hi, sir. Good afternoon.
When Bala talks, there is no doubt in the minds of people who are listening. That's what I said.
I believe this is a whole day module. I think, sir, if possible, probably we can do it for the PGs also sometime. I think sir is also planning.
We are coming out with an interactive module. Once it is come, they can register and log in and learn. No problem. That's a 1-year project.
Yes, sir. Thank you so much, sir. I think
8 hours.
Yes, sir. Thank you for simplifying the topic, and then I think you covered most of the principles in 1 hour. Probably all the principles were covered in stretch. Thank you so much, sir.
I thought people have stopped using masks. Are you not well? Your voice is not different from.
And I'm in hospital, sir. I'm in hospital.
Her mother is not well, I believe.
Oh,
sir. Yeah. Okay, thank you, sir. Ashray? Ashray?
Yes, ma'am. Yes, ma'am.
Closing remarks.
Thank you so much, sir.
One question. There is a question.
Is it irrational to give ceftriaxone plus azithromycin in enteric fever?
Absolutely irrational. See, in fact, in enteric fever, one drug is enough. And the combination therapy has not proven to have advantages. In fact, we have published from our own hospital about 15 years back. We compare the duration of fever and the time taken for deferescence when a single drug was used, which is in our unit, and where 2 drugs were used. And the duration of deferescence fever or total duration of fever is not different in either of the groups, indicating that addition of one drug does not add to the advantage. That's number one. Number two, majority of enteric fevers, at least 80% of enteric fevers, are all children who are not toxic, who are not very ill. They get better. What is the reason? Why? Where is the reason to use 2 drugs? You're only going to increase the levels of antibiotic resistance. Number 3, in a recent paper 2 years back from Nepal, they had compared single versus 2 drugs. They used catifloxacin plus azithromycin and or cefixime plus azithromycin. The duration of fever is less by around 12 or 14 hours. For reducing the fever by 12 to 14 hours, why do you want to give one more antibiotic? There is no reason. Third is, throughout the world, ceftriaxone and azithromycin resistant, multi-drug resistance enteric fever is emerging in a big way. We'll be only hastening it if we use 2 drugs for enteric fever. I have never used 2 drugs for enteric fever so far. So there is no rationale in using ceftriaxone plus azithromycin. If at all one wants to use azithromycin, it can be used, if you ask me, If for some reason you are given 7 days of cephalosporin, that is where the problem starts. 7 days, child is still toxic. It's not only necessary to consider a change of antibiotic, but also consider other diagnoses. That's what you should do in proven enteric fever, not addition of another drug. Okay.
Yes. Yes. Thank you, sir. Ashray, closing.
Thank you so much, sir. Thank you so much for such a wonderful session. And thank you, participants, as well, for being a part of this session. Hoping to learn from you more, sir. So, hoping for more such sessions, sir, more such great sessions, sir. Thank you, sir.
Thank you so much, sir.